joining online. Thank you for being here. I hope you're warm and cozy somewhere to watch this wonderful presentation. I am Shannon Brown. I am a professor in the School of Public Health here at Georgia State, and I'm chair of the Department of Health Policy and Behavioral Sciences. And you're here today for the first Grand Round Lecture Series of the spring semester. And our Grand Rounds Lecture Series is sponsored by the School of Public Health and organized by the Grand Rounds Committee, which is led by our very own Jelaine Arias, an associate professor in our school. And I just want to take a moment to really thank the committee and our staff support, especially Sam and Marcus, who have contributed so much to making this event a success. So thank you everyone who've been involved. I want to take this moment to tell you a little bit about our Grand Rounds Lecture Series. The intention is to bring nationally recognized thought leaders to the Georgia State University School of Public Health for dialogues that contribute to the school's mission of advancing health equity and solving contemporary and emerging health issues. The lectures are held monthly during the fall and spring semesters. So before I turn it over to Dr. Knish to introduce today's prestigious speaker, I just wanted to share a little bit about our upcoming lectures. So on February 28th, we will have Micah Berman, who is from Ohio State University and who will be speaking on tobacco regulation and policy. On March 5th, we will have Dustin Duncan, who will be coming to us from the Columbia Mellman School of Public Health and who will be speaking on intersectionality and positionality in health equity research. And on April 17th, we will hold our second annual School of Public Health Research Day, and we hope to see all of you at these upcoming events. So it's my pleasure now to turn the microphone over to my dear colleague, Dr. Kelly Knish, to introduce today's speaker. Dr. Knish is the director of the National Center on Child Trafficking that is housed in our School of Public Health within the Mark Chaffin Center for Healthy Development. Dr. Knish joined our school when the center was established in 2020. She had a remarkable career at the Georgia Center for Child Advocacy prior to coming to Georgia State, serving children and families impacted by trauma in Atlanta and around the state. And I see many of our GCCA colleagues here today, so thank you for coming. Kelly and I have been collaborating on human trafficking prevention and intervention services and research for more than a decade. It's been a wonderful partnership, and we are thrilled to co-host this Grand Rounds today in partnership with the School of Public Health. Thanks, everyone.
Thank you, Shannon. I wasn't expecting an actual introduction. I'm just sliding in here to introduce Hanni and say a little bit about our center. Thank you for that. As you said, it's really my pleasure to lead the National Center on Child Trafficking. We are a collaboration of individuals with expertise, both professional and lived experience expertise in child trauma and trafficking. We work together to develop and disseminate trafficking interventions and resources. We are part of the National Child Traumatic Stress Network, which is a really fantastic network of now almost 200 organizations throughout the US and territories, specifically focused on child trauma in its many forms. We are in the network what's referred to as a Category 2 Treatment Services and Adaptation Center. And we're the first of those in Georgia, which is really quite an honor for us. Our role within the network is to be experts in child trafficking specifically and to develop, adapt, disseminate resources specifically to improve trafficking response. We have a responsibility, I think, to bring trafficking knowledge and expertise into the network. And we also have this really wonderful opportunity to take the expertise in child trauma of the network more broadly into the larger anti-trafficking field. We have 4 focus areas for the center. Our first, and probably the one that's the closest to our hearts as much of the leadership, we are mental health professionals ourselves, is mental health treatment, especially with a focus on trauma and substance use. We also have a focus on trauma-informed caregiving and placement, as well as multidisciplinary team coordination and case management, and finally, and intersecting with a lot of those, workforce development and secondary traumatic stress and compassion satisfaction. I would like to invite you to learn more about our center and trafficking by visiting our webpage. You can hit the QR code here. I would also invite anyone at the university, in the School of Public Health, in our community who has an interest in learning more to reach out to me directly. I think I put my email on there. I know it's really small, but it's there. Please contact me directly. I'm very interested in having conversations with people about our work. So telling you a little bit about the National Center of Trafficking is the second best thing I get to do today, and I think my favorite is introducing our speaker. January is National Human Trafficking Prevention Month, and it seemed like a really perfect opportunity to bridge the work of the National Center on Trafficking with this School of Public Health Grand Rounds Forum, and really no one better to bring to this stage than Dr. Hanni Stoklosa. So Dr. Stoklosa, who's in the wings here and is going to like slide out and do something really fancy on the stage, I think. She's an emergency physician and assistant professor at Brigham and Women's Hospital in Boston, Massachusetts. She's also, I want to make sure I get all of this right. She has appointments at Harvard Medical School and the Harvard Humanitarian Initiative. She is truly an internationally recognized expert and advocate and researcher on the well-being of trafficking survivors in the US and internationally, importantly, especially for today's purpose through a public health lens. She's advised, impressively, the United Nations, the International Organization for Migration, the US Department of Health and Human Services, Department of Labor, Department of State, the National Academy of Medicine on issues of human trafficking, and has had an opportunity to testify before Congress on multiple occasions around these issues. She has a pretty lengthy list of awards and accomplishments, just to hit a couple of them. The Department of Health and Human Services identified her as the Women's Health Emerging Leader Award. She was named an Aspen Health Innovator and National Academy of Medicine Emerging Leader. And she's conducted research on trafficking and persons facing some of the most significant social, economic, and health challenges in places such as, and this is quite a list, Austria, China, Egypt, Guatemala, India, Liberia, Nepal, Kazakhstan, the Philippines, South Sudan, Taiwan, and Thailand. And she did mention at dinner last night that's like that she needed to update that list. So she's also co-editor of the first textbook addressing the public health response to trafficking. Human trafficking is a public health issue, a paradigm expansion in the United States. It's a really fantastic resource. And I would say perhaps most importantly and most impressively, she's the founding director of Heal Trafficking. So this is, Heal Trafficking is a network of over 4,000 professionals and survivors throughout the world, 45 or 50 countries, I think she might clarify. And Heal is really dedicated to ending human trafficking and supporting traffickers from, in particular, a health perspective. She saw that there was a need and an opportunity for the healthcare system to better recognize and respond to trafficking. She started Heal to make it happen, and I would say the impact of Heal has really been nothing short of extraordinary. I know personally she honors and elevates diverse expertise and partnership with individuals with lived experience. She believes in collective impact and the essentiality of service to others for the greater good, and she is, I would say, quietly tenacious and tireless. Thank you for being here, and welcome, Dr. Stoklosa.
That's so sweet. Thank you so much for those words, Dr. Kanish. Good morning, everyone. Good morning. Let's try that again. Good morning, everyone. Good morning. For those who know me, my father's a pastor, so I gotta do that. It's sort of in my blood. I am really thrilled to be here today, and thank you so much for the invitation. I believe each and every one of you, whether you're here in person or tuning in, is here for a reason. And my hope and my intention for this space is that not just the words that I share, but hopefully the way that I help you to think will impact someone who's experiencing trafficking and set them on a path of healing, or maybe even prevent someone from being trafficked as a result. So I appreciate you entering into this space and opening your hearts and your minds. For me, this has been a journey, and I'm going to talk about kind of my own journey of learning and unlearning in this space. And so much of it has been grounded not only by the research that's been out there, but most importantly, effective communities and listening to those who've experienced trafficking. And not just learning anew, but figuring out what I need to think differently about. As you know, I'm an emergency physician, so as I share this, one of my really important lenses is from that healthcare perspective. And each and every day, I practice what I preach and am constantly learning. And so I hope that this sharing of this journey will be helpful for you. This statistic, 68% of trafficking victims have a touch point with healthcare, was my own inflection point to recognize that trafficking was a calling for me. This work is a calling, and I realized that of that 68% of labor and sex trafficking survivors, both those born in the United States, those that were not born in the United States, were coming through healthcare, the number one place was emergency departments. And when I learned this, I realized that there was no looking back for me, that this was the issue that I was going to dedicate my life to, so that we can build a movement in healthcare to respond to trafficking. But that movement has to be imbued with public health approaches. We cannot arrest or prosecute our way out of trafficking. And so I see that healthcare, public health response as synergistic and absolutely necessary. So I'm going to invite you to first just join me in this thought exercise. When you hear, maybe it was when you heard this lecture was coming up, you knew it was about trafficking, or even just as I say the word human trafficking, who comes to mind? I want you to try to just pick the first image that comes to mind of a person and try to think about them in a very kind of detailed way. Is there an ethnicity or race that that person has? Sexual orientation, gender? Is it a type of trafficking that comes to mind? Labor trafficking or sex trafficking? I just want you to think and hold that kind of mental image of who comes to mind first for you. So, I'm not going to ask for folks to shout this out, but did that person look like Pedro, who was labor trafficked in southern Georgia on a farm? Or Sean, who identifies as transgender, who's a Cherokee Nation person who was sex trafficked? And I also want you to think about the why behind that. We are human beings in this world where we're constantly bombarded with, and it feels like more and more every day, images and news and stories. And so much of who we are is just informed by what we see visually in the media about trafficking. But we know trafficking is so much more than what we see in the media. And I wanted to share some specific examples right here in Georgia, a recent case. This is the kind of press release that the government puts out, and this one was, the press release was in 2023. So, of a trafficking case of in 2 Mexican restaurants here in Georgia. This may or may not have been what came to mind for you. Also, not that long ago, Operation Blooming Onion. Blooming Onion because this was agriculture sector. The exploitation of workers from Mexico, from Honduras, in the southern district of Georgia. And I'll just share some of these things. I know this is a lot of text on the screen, but required the workers to pay unlawful fees for transportation, food, and housing while illegally withholding their travel and identification documents, subjected the workers to perform physically demanding work for little or no pay, housing them in crowded, unsanitary, and degrading living conditions, and by threatening them with deportation and violence. The exploitation of the workers included being required to dig onions with their bare hands, paid 20 cents for each bucket harvested, and threatened with guns and violence to keep them in line. Their workers were held in cramped, unsanitary quarters and fenced work camps with little or no food, limited plumbing, and without safe water. And they also experienced raping, kidnapping, threatening or attempting to kill some of the workers or their families. So as you, who I hope each and every one of you ends up being a champion for trafficking in some way, shape, or form. And I'm going to continue through the beginning portion of this lecture just to share some local examples, but also some different examples than what you might have had initially in your minds when you think of trafficking. These are statistics that are pulled from the National Human Trafficking Hotline from the state of Georgia as well. So we see that number one in terms of so these are calls, or these are reports that come into the hotline. They don't necessarily equal each and every one case, or it could equal one case but involving multiple people. So it's a form of data. And we can kind of get a sense of kind of proportionality of what gets called into the hotline. But here at the bottom, related to that first case we heard, we have restaurant food service, illicit activities. So many folks don't think about someone being forced, for example, to sell drugs as a form of labor trafficking, but forced criminality is another form of labor trafficking that may not come to mind. Factory work, domestic work, and agriculture or farms. So I know we have some experts of human trafficking in the room, but just to kind of level set, what are we talking about here? And why is this such an expansive crime that impacts so many populations? Well, to start off with, the definition really helps you to understand how this can impact so many folks. So as an emergency physician, like I'm constantly thinking about my patients, and I'm really thinking about, how is a crime like written out? So it's a little bit of a sort of mental gymnastics the first time you think about a crime being perpetrated against an individual, but that's how crimes are written. So this is the crime of trafficking that's being perpetrated that we're talking about. And it's not a passive crime, right? There's an action that the trafficker will perpetrate, and then there's a means, and then there's a purpose. So just kind of walking through these very quickly. For labor trafficking, a trafficker may be involved in any stage of bringing a victim into a country. Someone might be trafficked within their own home, or even the recruitment process. For labor trafficking, the purpose is for forced labor, and we saw some examples in those cases from Georgia. And the means, forced fraud or coercion. So these are kind of legalese terms. How do they actually break down? Traffickers will, as we saw in one of the cases, they will often use multiple methods to keep their victims essentially in a pattern of feeling like they can't leave that situation. We heard about threats of deportation, threats against someone's family, the use of sexual assault. All of these things are often used together to keep somebody essentially a virtual prisoner and not able to leave that situation. And then for sex trafficking, the same thing applies for adults, but very importantly, under the age of 18, if anyone is engaged in commercial sex, it's considered to be trafficking without that forced fraud or coercion component. And then for adults, to recognize that choice and consent can change from hour to hour, day to day. Someone may, in some circumstances, be in a situation of, where there is forced fraud or coercion, and that might change. It might change depending on where they're living or who is involved in that situation. I think it's really important to hear from survivors themselves, and also just to see them talking about their experiences to even bring this further home. So we're going to play a short video clip of survivors talking about their trafficking experience. I want you to think about what might be surprising to you as you watch this.
Our trafficker in our trafficking situation and get the proper support.
I got help through a public health nurse.
My trafficker and I went to the clinic to get TB test and physical exam.
I went to a dentist. There is many work conditions for labor trafficking survivors. We have domestic servitude, we have factories, we have restaurants, construction.
I thought I was going to be living with my husband and practicing my profession as a journalist, but instead, I got trapped in a house.
So my trafficker is a woman and she's also Filipino. I work as a caregiver in reward and care in Long Beach. It's a house setting and we're taking care of elderly, retired.
So I have a skill in hair braiding, so I will braid this hair, people will pay money, and once they leave, they will collect the money.
I was working in someone's house, taking care of kids, doing all housework, 14 to 16 hours per day. And the pay was low.
I was the driver, I was the office cleaner, I did the jar, I did the clothes, I was cooking, I was doing anything and everything. The conditions were very different for everyone.
Sometimes I was working up to 14 hours a day and I only eat one time a day. I was just braiding and braiding and braiding. And by night, I'm so exhausted.
I'm sleeping less hours. Like if you go to bed, you still go to bed late, but you're still working because when you are asleep and you woke up, watching the kids or baby's crying or you need to take the baby time, but still you're still working. And without pay off.
There was a time that for 6, 8 months we didn't get a day off. So we straight work for 16 or 18 hours a day. I was exhausted. There was a time that I even feel like I'm gonna kill myself.
It's just hard to speak. Many threats are to the family members, to the loved ones like your son, your wife, your mom, your brothers. And traffickers tend to use that against you a lot in front of anybody.
I was isolated. I couldn't go anywhere at will. It was always following me like a prison warder. And then it was threatening me with immigration and the police.
And she told me that I owed her $12,000. And she threatened me that she's gonna call the police and tell the police that we stole something from her if we try to escape.
God, I'm praying for freedom. Police was what he was using to threaten me.
Thank you. Was there anything, I'd love to make this even more interactive. So what surprised you and what has been surprising so far as you're hearing about what trafficking involves, the people it impacts? How varied and diverse. Thank you. Yeah. It's in plain sight. Anything else? Yes. The threats to use the government against them. That is something that I've heard in every country that I've worked and right here. And that even whenever trafficking victims go to healthcare, they're worried that if they tell somebody, they'll be deported. Any other things that kind of stood out that were surprising? Yeah.
The types of labor that people were engaged in besides, I always thought of farming as the main labor trafficking, but to see even something like hair braiding being used.
The types of labor, including hair braiding, just for those that are tuning in. And that's Bukola, who we wrote this paper together. She was labor trafficked and was pregnant, so actually had a lot of contact with OBGYNs while she was being trafficked. And her story has really powerful lessons for health professionals too. Anything else? Yep. Differences in ages. Yeah, yeah. Anything else?
It can feel hopeless.
It can feel so hopeless that, as Angela shared, like she wanted to kill herself at a certain point. Yeah. Thanks for sharing as your learnings as we're going along here. Okay, well, I didn't realize this. I didn't realize I'd advanced the slide as I turned around yet. So you're probably wondering why I have this slide of Taylor Swift. And I mentioned I'm going to share some of my own unlearning. And part of my own journey of unlearning around trafficking was that I really, as this naive new physician, I imagined that if someone was being trafficked, they were just going to come into my emergency department and ask me for help. And they would just be like, just please, please help me. And it's now, you know, having read about this phenomenon, it's kind of this like, there's a term for it, it's kind of the perfect victim, that in one's mental model or mind's eye, that someone who's experiencing violence will be like kind of this perfect victim. And for each of us, that mental model might look different. And so I had to unlearn that. And what was also really important for me in my own unlearning was understanding the way that trauma rewires the brain. And understanding that trauma can really put people in fight, flight, flee, or fawn. And that is actually beneficial evolutionarily. That's actually a protective mechanism, that allows that person to survive each and every day in their situation. And so even the ways, not just the kind of diverse demographics or sectors someone might be trafficked in, but the way that they're going to show up in my example in the clinical setting is not how I had in this sort of fictitious world in my mind, but to really understand how trauma impacts the brain, and for me to get curious about behaviors that I see, and rather than using negative labels, to really want to understand what's underlying someone's behavior, and that underlying that might be trafficking. So just to kind of summarize this bucket of unlearning, all humans, including health professionals like myself, but all humans, we all have bias about who experiences trafficking, and how trauma manifests. And the first step is to recognize where those biases are and to unlearn them and to mitigate them. The question is not whether I have been shaped and participate in the forces of racism, it's how I've been shaped by them. It's how I've been shaped by them. I think this is a really important part of the conversation for the public health response to trafficking. And really key to that is understanding this fundamental difference between equality and equity. And this is no surprise for many of you in the room. Many of you have seen slides that are kind of similar to this. But I think what's really important to recognize is that doing anti-racism work and doing equity work involves an active process. It's not enough to kind of uniformly apply all of our efforts, but really to look at where gaps exist and then to actively work to mitigate them. So these bubbles here are my kind of word art representation of where we see most of the funding for anti-trafficking response in the public health sphere, and then where we actually have a lot of evidence. So what do you see here, depending on whether you have your glasses on or not, because I know some of it's tiny. What do you notice about where the state of affairs is? Yep.
All the money's going to sex trafficking interventions.
Mm-hmm. Sex trafficking, and then the smaller ones, which are probably hard to see in the back, are those who identify as female, children, and commercial sexual exploitation of children, which all of these things are really, really important. But we're at a state right now where there's so much less that's understood about the public health response to labor trafficking and to gender and sexual orientation minorities. And we have so far to go, BIPOC populations, to really understand fundamentally prevention, intervention, and even just those basic descriptive understanding of the state of the problem and how it differs. We have a long way to go, and we have a lot of time that we need to make up. In particular, around labor trafficking, just one note, and I was talking with the students about this morning, that even the ways our laws, when they were first put into play, our federal statutes on trafficking, deprioritized labor trafficking. So none of this is by accident. It's, if you look at the history of the ways that even our laws were created, have set us up So it takes us as equity champions, as public health equity champions, to really step up and speak up about these disparities that we're seeing in the trafficking response and make them explicit rather than silent. So to summarize this piece of my unlearning, if I'm not actively mitigating inequities, I'm contributing to them. Overcome inequities by focusing on the forgotten. And just one example is labor trafficking. And labor trafficking does disproportionately impact BIPOC populations. So I'm a physician, and we take the Hippocratic Oath, which is to first do no harm. And I think many of us in the room probably live by a similar ethos, that everything that we're doing, we're hoping that it has a positive impact. We're not actively trying to do harm in the world. But what we see as we look across a lot of the very well-intended anti-trafficking space is that people are just kind of like trying things that make sense. And those trying things that make sense to them as a caring person may actually do harm. And that needs to be stated and spoken. So this is not a trafficking example, but many of us know the impact of the war on drugs and how it disproportionately incarcerated Black people. But if you ask many people, they thought, oh, this is just, you know, a war on drugs. It's helping to fight drugs, that there was a good intent. But the reality is that it did so much harm, and on a large scale. So thinking about in the trafficking space, and then let's go to my world of healthcare. What are some examples of things that could, you know, might feel like they were the right call, but they could actually be harmful? I'm gonna start us off with this. A policy to call 911 for trafficking victims. What could be bad about that in a healthcare setting? Just potentially, like just hypothetically. What could be bad? Not. People don't come into healthcare. Why would that be? People, they don't want to be incarcerated or in trouble.
I was going to say someone might be trafficked by forced criminality, and then the police don't understand that, don't have the training to understand that, and then now this traffic victim is in trouble.
Yeah, so this is a really great, so if somebody's trafficked by forced criminality, law enforcement might see the crime and not the victim there. Absolutely. Any other problems with that? Yeah, so they might, so let's say they go to the healthcare setting, 911 is called, and then they go back to their trafficking situation, and they might actually experience even more violence from their trafficker because of this repercussion. So now the trafficker is kind of more on the law enforcement radar. Yeah, there's a lot of different ways this plays out. And you know, I mentioned earlier that like fear of deportation, but the concerns about law enforcement engagement, when the wrong law enforcement is engaged at the wrong time, it really can do harm. So that's just, you know, one example. Here's another example that I think is a little bit, maybe more of kind of an insidious harm, but somebody shared this picture with me. It was like circulating on Facebook a little while back, and they were like, "This is the best thing ever," and I'm like, "Okay, let me look at this critically." So I want you all to kind of put your critical thinking hats on. So this is a sign that is in a patient bathroom, and it says, "Please put only your initials on your specimen." So this is like a urine specimen. You know, you have to give you might need a urine test when you go into a clinical setting. So you're in the bathroom there, giving a urine sample. So please put only your initials on your specimen and place it on the back of the toilet. Your nurse will collect your specimen. Thank you. Sharpie. Please write your initials with the red marker on the specimen cup if you are experiencing intimate partner violence, domestic violence, or anything else you wish to discuss in confidence with your provider. We will ask anyone accompanying you today to leave the room before discussing your concerns. So just like even with the 911 thing, there's potentially for some good, and then there's all these potentials for harm. Here there might be some like bigger potentials for good, but there also could be some harms, or some people that are left behind, a harm in sort of more of a passive way. So thinking about that, who is left behind? What are the potential harms from this? Yeah.
Well, anyone who can't read or doesn't understand English is not getting the message.
Yes. Okay. So if you can't read or understand English, you're not getting this message at all. Exactly. What else?
They don't understand your victimization, and they don't regard it as domestic violence or intimate partner violence, and they can stay.
Yes. So these are labels that, like, I use. They may not be the words that someone would use to describe their experience. So if they don't see themselves in these words, then they're not going to, use that mark, which is definitely the case with trafficking. What else? Yeah.
Well, it says if they can understand it, it says in confidence, which suggests that you might be able to have a conversation without it being recorded, which is probably not actually accurate. So they might engage in something like this and then end up in a situation that they didn't anticipate based on this.
Yeah, like what are the assurances that this is actually, what does confidence mean, and what are the assurances that that's actually, like they're actually in place and it's not going to be a broken promise. Any other thoughts? And yeah.
The onus is on the individual and not the provider to have the conversation.
The onus is on the individual and not the provider to have a conversation. Yeah.
Anybody who doesn't use the male/women's restroom, as well as anybody who doesn't feel like they can do a great job at acting like everything completely normal and cool, their accompanier is passively.
So, I mean, there's a couple of scenarios where this could go awry. So first of all, on the including, excluding, this might not be in all the bathrooms. It might be in gendered bathrooms. So who are you missing there? And then will there, are they actually truly alone in that bathroom? It might raise some alarm bells if they're with somebody. And even just the way that if they've disclosed in this way, will they be acting differently and give off sort of some red flags to somebody that was with them, accompanying them to the healthcare setting? Those are interesting ones that haven't come up before whenever I've shared this. Any other thoughts? Great. But you can see how, at first blush, it seems like a good idea, right? Wait, is that in their hand? Did you ever? Okay, sorry. You're allowed to fix your hair. I'm not going to call you. But there's that initial, and that happens so often in the anti-trafficking space, where it's like, I have this good idea, and I'm sitting here in this positionality where I actually have a lot of power and control, and I have a very limited lens at what this experience is like. And so just another example of where good intent doesn't lead to good results. Increased use of alcohol as a result of DARE. The other piece to this all is that there's this kind of trafficking is this new thing that we need to figure out. But the reality is that so many other forms of violence that we've been looking at for years and building a rich public health evidence base, we can look to those spaces and we can look to the implementation science to learn from the mistakes so we don't have to make those mistakes again, and build on that rather than starting from scratch. And then this is just another example of unintended consequences, even just the way things can be misunderstood. So this is a parking kiosk, and everyone thought they were supposed to park on the kiosk. So what's the solution here? So the solution is to talk to people who are impacted, right? So to involve not only people who are currently or have experienced labor trafficking or sex trafficking, but also those affected populations. So migrant workers, those who are engaging in commercial sex, will be able to really inform your interventions so that you're able to make them as impactful and cause the least amount of harm, but most importantly, to be positively impactful. So don't assume good intent. I think that's the baseline, is to bring that critical thinking lens and to realize that Good intent does not lead to good impact necessarily. It can lead to harm. And the key is really to listen to those who are impacted. So in summary here, know your biases, mitigate them, overcome inequities by focusing on the forgotten, like, for example, labor trafficking. Good intent can lead to harm, involve affected populations, and do your homework and bring that critical thinking lens. I know we do have some folks here who are specifically in the clinical setting, and for those of you who are public health researchers who are informing how we think about assessing for trafficking too, I wanted to specifically talk about that as well. Again, this is part of my own unlearning journey. So I was sharing with the students earlier this morning that when I was that newly minted doctor and I was like, okay, I'm worried this person's experiencing domestic violence. The way I had been taught and the way that I saw that being assessed for was, do you feel safe at home? How much do you drink? Do you do drugs? Okay, what are you here for today? And that's what I saw. So you learn by seeing the way that those who are your mentors, et cetera, do things. And so my initial instincts around trafficking were, well, we just need to get the right questions. We need to get the right words. But also, on just first blush, as I was seeing people do this assessment, I'm like, that just doesn't make sense on a human level. Like, I wouldn't respond to that. Like, and so we need to do things differently, but how do we do that? And so I looked at the literature from domestic violence and really wanted to understand how kind of screening and assessment, what we've learned from that to inform what we're doing in the trafficking space. And what I learned was that we need to, first of all, it's not about rescue, which is so counterintuitive for me as an emergency physician. Like, I went into emergency medicine to fix things, right? And that is in like my DNA. But as we listen to survivors of all forms of interpersonal violence, what they say is healthcare, I feel disempowered. It's fundamentally a situation where I have less power. And I need you to give me information. I need you to give me resources so that I can make decisions. I need to feel safer, and I might need help thinking through that. But it's not about you getting me to tell you something or that you're gonna take me out of this situation, because I know my safety best. And I'm doing that mental calculus as a victim, knowing who's being threatened in my family, including potentially my children, and I need to make the safest choice based on all of the considerations. And what do you as a doctor actually have to offer me? And so as I did that listening work, it really impacted the way that I approach assessment of trafficking. And there's a few ways of saying this, but one of the goals is, to create that open door that someone will feel safe in my healthcare facility, that if and when they're ready to leave that situation, that they know where to get resources. The other way it can be said is planting seeds, right? One trafficking survivor colleague told me that, it may take 50 caring individuals to plant a seed with a victim of trafficking. Plant a seed of information, of hope, of resilience. And as the caring health professional, you don't know where you're at in that person's journey, whether you're the first person, the 25th, the 49th, or the 50. But what I can control is planting that seed, right? And so those are the reframe that I've needed to do myself. And then in the vein of like not doing the turning around, turning my back and just citing off a list of questions, a framework that builds on the domestic violence approach to assessing for domestic violence is the PAIR tool. This was co-created with Pacific Survivor Center, Common Spirit Health, and Heal Trafficking. And it's simple steps that include asking a question, but it's not the primary piece because all of the rest of the context is really, really important. If someone feels like I'm judging them, they're not gonna tell me anything, and they're not even gonna listen to any resources I might share, right? So the ways in which we approach someone who's potentially exploited is just so, so critical. So P stands for privacy, E is for educate, A is for ask, R is for respect and respond. We do, in my own emergency department, a lot of the victims that we identify have co-occurring substance use. Many of them, it's opioids, partly just based on what we're seeing regionally. And so whenever I have a patient who's using substances and comes into my emergency department for medical reasons, I'll find some time and space to talk to them privately, which I have to tell you right now, it's the clinical environment is very, very crazy, and sometimes it takes a lot of work to do. But when I have that moment alone with them, maybe it's an x-ray, maybe it's walking them to the bathroom that's what seems like 5 miles away, but 5 turns away. I'll say, as your doctor, I care about your health, and I talk about the thing that they're there for. And a number of my patients who use, insert whatever drugs that we've talked about already, heroin, meet the wrong drug dealer who ends up controlling all of their life, maybe threatening them or their family, and they feel like they can't leave that situation. Has that ever happened to anyone you know or to you? And then I just wait for a second, and I also say the reason I'm asking is that we have resources to help people that are in those situations. So that's just one way of using this tool in one specific example, but it's customized. It's personal to what I've already talked about with that patient as part of their clinical care, and it leaves the door open. Sometimes I get spit at. Sometimes I get that, that's actually happened to my friend. I can just see the wheels turning, and depending on my concern for their safety, there's a number of different paths that I can take in my healthcare setting based on our policies and the resources that we can offer. But I provide this tool because it flips the script of power, right? It's giving that person the control in the conversation, and it's not about me or my agenda. And then another thing just to underline here, I don't know if this was so much of an unlearning for me or of a more of a, wow, this is so fundamental in a way that I didn't realize to this extent, is the use of interpreters. So we know that many folks who experience trafficking, English is not their primary language, but this is actually a medical record from a trafficking victim who was picking corn and got heat stroke and came to an emergency department. And the clinician actually wrote, this is back in the olden days when we wrote words and medical records on paper, but this is that trafficking victim's medical record. It says, poor historian, due to language barrier, very little English. That should never be written in a medical record. And since then, I've also heard just from so many trafficking victims that they went to healthcare and their trafficking was missed because there was not an interpreter that was used. And so for those clinicians who are tuning in, for those of you who work with clinicians, this is just something that I can't underline enough. And then we are at a phase, thanks to amazing research, including folks like Jordan Greenbaum, who are in the room today, who have helped us to, when we get to the ask, when we get to the A part of the PAIR tool, we have questions that have been tried and trued in different settings that we can ask, and I'm not going to go through them now, but inclusive of labor and sex trafficking. Dr. Knish talked about heel trafficking at the top, but this work really is a calling, and I implore you, and I also invite you to join our network of health professionals. It's a global community that we've created, and it's you can just go to healtrafficking.org to sign up for our online community, and there's discussions about the latest in evidence as well as education that's coming out, and a myriad of curated resources on our website. So the tools are there. We are now at that phase where the tools are there in healthcare to respond to trafficking. So I encourage you to join the movement. So we got so I see each of you today as kind of like that water droplet that's hitting the water there. I'm so excited to see the impact of this conversation and this time that we've had together to see the ways that the information and the ways of thinking that I'm sharing with you may ripple not only into your professional work, but into the communities that you touch, to the families that you touch. And I want you to think and reflect on, based on just this brief time together, how you might be thinking differently about trafficking. Is there one commitment that you want to make today? And I encourage you to even maybe jot it down or type it in your phone. I'm still a paper and pen writer. How will you think differently, and what is one commitment you may make today to change the way that we're responding to human trafficking? And for those of you who are on the younger side of things, to think about how this might shift or change the work that you do going forward in public health. I don't know if anyone wants to share. Also don't have to. But just curious at how this may have shifted the way some of you are thinking. Jordan? Yeah.
It shifted I think you make an excellent point about thinking about the potential harm in anything that we decide to do. That we need to think about what are the negative impacts. It's really tough.
Thank you, Jordan. So underlining the thinking about what is the potential harm. Yeah.
For me, it was like kind of outreach almost, like learning how to recognize the signs because a lot of us don't. But when we do kind of recognize the signs, what is the best response? How not to make them feel unsafe? You know, in the sense that feel like they can trigger, they can endanger them.
So thinking about the actual response in real time based on what you're seeing in that person's verbals and more importantly kind of their nonverbal communication. And really kind of putting yourself in their shoes is what I'm hearing from you. Yeah.
The work I do is very focused on the 3 bubbles you had up there: sex trafficking, the female.
Which is so important. I don't think.
Yeah.
Yeah.
What you said about overcoming inequities by focusing on the forgotten, that really stuck with me. So that's how I think differently and really meditating on that.
Thank you for sharing. Thank you.
I want to work in healthcare eventually, so it's kind of giving me a lot of insight and help us to empathize and just really think from their point of view. Being in that healthcare environment, what's going to be scary and what's going to be safe and being in that environment and be able to answer or receive the help that I have.
Thank you for sharing. So someone you're going into healthcare and like thinking about how you can flip that script and give power back. Yeah. Yeah. Did you he was touching his hair. I'm sorry. Anyone else wants to share? Yeah.
Yeah, I think it's so simple, but just really listening to the survivors and their needs and what they feel is best to empower them instead of trying to think from wanting to help them from our perspective and really what do they need versus how do we want to apply our knowledge.
Listening to survivors. Yes. That's a lot. Those are all gifts, and they're gifts that you're giving to each other by sharing too. So thank you. Thank you for that. So as we look back at the history books from today, think about these commitments and how things will be different as you change history from here on. I often go back to this quote from William Wilberforce, who is out of the UK, a famous anti-trafficking advocate, but I think these words just so much resonate with me and my how I think about approaching life in general. But great indeed are our opportunities. Great also is our responsibility. So thank you so much for this time together. I think we have like a couple minutes for questions, and I'll hand it back over. Thank you.
Thank you so much for that amazing presentation and really for helping shift our mental models and really for helping to give us the bravery to think about what we need to unlearn. I think sometimes we always approach it with what do we need to learn, and we forget about the aspects that we need to attend to in our own unlearning to really do this work well. We would love to open it up to the room for questions. We have a couple of amazing students who are serving as volunteers and are going to run the microphone around. So it looks like we have one. Dr. Arias, was that a question or that was a hair? Gosh, a lot of hair. One question I have is, for the students in the room, how might they engage with the Hill Network in some way as they're thinking about expanding their professional network and maybe learning more about trafficking?
Yeah, I love that question. So it's, I think I'm getting feedback over here. So the question was around how to engage with the Heal Network. So it's really as simple as going on the website and there's a Join Us button, and you can sign up to be part of just the community in general, and that's really just kind of like a listening space. But there are individual online forums for education and training, research, advocacy, direct services, and protocol development. So as I said, we are a public health framed organization. So in each of those buckets, while our focus is on healthcare, we have folks who are survivors of trafficking. We have folks who are in law enforcement. We have legal professionals, and we have public health professionals. It's a really multidisciplinary group of folks, and people will send out questions and ask, does anyone have a resource for this? Or I'm thinking about this. It's also a place where some people recruit for studies as well. So because it's global and it's over 4,000 individuals, you can it's a sort of that hive learning, and you can really learn from so many other individuals who have different perspectives across the globe. So yeah, it's as simple as signing up.
Fantastic. We'll go to Dr. Whitaker and then to Dr. Hyman.
Hey, thanks. Now that my hair is fixed, I do have a question. This may be too amorphous, but since we're in public health here, I wonder if you could say a word about the state of primary prevention for trafficking, that is trying to prevent it before it happens, and what I would imagine it to be very difficult, but just kind of curious where things are on that.
Yeah, I'm trying to, I actually have all these slides that I did not use, there is one that I want to use to help reference. Okay, so when we think about primary prevention, I think it's partly thinking, first of all, describing the layers of risk as well as resilience to look for where those spots are for primary prevention. And so those layers, all of you here at the Public Health School don't need introduction to this, but of course we have our societal community relationship and then individual risk factors. And I'm a strong believer in understanding resilience as well. In the anti-trafficking space, there's not been a ton of research on that as of yet. There was one study that I was involved in, so that's why this is reflective of risk and not having all the layers of resilience, but I was involved in one study where we looked at runaway and homeless youth in the New York, New Jersey area who were trafficked. And we actually found a resilience factor that youth who had a supportive adult in their life, as they defined that, totally like just their language and words, were less likely to be trafficked despite all of the other myriad layers of risk they had. So I'm just sharing that as I show this model. So I also think there's a long way to go in terms of primary prevention, but I think some of that is actually the fact that there are many things at these bigger layers, like there's intersectionality movements, including disability rights, housing first models, where they're not necessarily looking at trafficking prevention, but when I look at them, I'm like, there's no way that this is also not, like, by housing people, like, you have to be preventing trafficking in the first place. So I think some of those really great intersectional spaces need to start actually measuring impact on primary prevention of trafficking, because my guess is it's there. So that's a long-winded way of saying I think we need to do better both at measuring as well as moving the needle in primary prevention. So thank you for that question.
So just echoing the thanks of others for both your presentation and even more so for your leadership on this issue. I'm wondering, particularly as I look at the community and societal risk factors, whether the HEAL Network has a policy and advocacy agenda, because clearly from where I'm sitting as a public health policy person, there are critical policies that can serve as either protective factors or risk factors.
Yeah, the way to do sea change, like big sea change, is to actually engage in policy. I wish we were like even bigger and we were like had a whole advocacy arm. We do have advocacy component to our work. Actually, the A of HEAL stands for advocacy. And we sit on a test. So we leverage our expertise on public health and trafficking by sitting on a coalition of anti-trafficking stakeholders and serving as the public health and healthcare experts in that federal space. And so, you know, there are a number, we're always looking at legislation in those spaces, including things for worker rights. Everything touches, there's so many issues that touch on trafficking and can be really fundamental for shifting those societal risk factors. So yes, absolutely. And then one of the other things that I've been noting as well is, so you know, there's the federal landscape, but there's so much that's happening even on a state level that really impacts those societal risk factors as well. So I encourage you, like, you know, this is another way that you can leverage not only your public health expertise and kind of like what you would imagine is your public, your professional work in your day-to-day, but leveraging what you're seeing and giving voice to that in legislature, even on a state level, really can be impactful. So thank you for highlighting that point.
Thank you so much. I think we're already at the end of our hour,
Thank
and
you.
I just want to say a huge thank you again, and you're just such an inspiration. Thanks for making this your life work. We're all better for it.
Thank you.
Yes. Thank you.